A very good afternoon to one and all. Hope you all are safe and healthy. I am Dr. Franny Nathani, Assistant Professor at Sancheti College of Physiotherapy, Pune, and I welcome you all to one of the most awaited panel discussion today. I welcome our esteemed panelists, our chairperson for the session, and all our dear delegates. I assure all the viewers that this session is going to be very brainstorming since the topic is very interesting. It is the role of mirror neurons in neurorehabilitation. And our panelist and moderator have expertise in the field of mirror neurons. But before we go ahead, I would also like to express our sincere gratitude to Dr. Giacomo Rizzolatti. Due to some unavoidable circumstances and his ill health, Sir will not be able to be the fourth panelist for today. But nevertheless, we are moving ahead with all the three panelists and our moderator. So without any delay, I would like to I take this opportunity to introduce our moderator, Dr. Lakshmi Prabha Devi Prasad ma'am. Dr. Lakshmi Prabha is Assistant Professor at St. GS Medical College and KEM Hospital. Ma'am has 24 years of experience with 20 years of UG teaching and 15 years of PG teaching experience. She's also a PhD scholar. Ma'am has 12 publications in national and international journals. It's our honor to have you here with us, ma'am. A very warm welcome.
Thank you. Thank you so much, Franny, for inviting me to be the chairperson of the session. It's really a big honor to be a part of Scientifica. And without more delay, I would like to introduce the panelists for today's brainstorming session. We have our panelists, Dr. Uttara Mohan, Dr. Vijay Kumar, and Dr. Dorcas Gandhi. Dr. Uttara Mohan, can we have her video on so that I can introduce her? Dr. Uttara? Is Dr. Uttara there with us? Yeah. Thank you so much. I'll just introduce you to our audience. Dr. Uttara is presently working as a neurophysiotherapist at Physiotherapy OPD ARH Center, Mumbai. She is a consultant physiotherapist and proprietor at Physio Finesse Clinic, Thane. She's a state sub-coordinator in IIP Women's Cell, Maharashtra, a co-opted state EC member in IIP Maharashtra, member of IIP Digital Media Team. She has a lot of awards in her kitty. She has awards for outstanding achievements in neurorehabilitation at Paraplegic Foundation, Mumbai, given to her in 2016. She has received the Gandhi Award for significant contributions to neurorehabilitation at Indian Federation of Neurorehabilitation Conference in 2017. She's received the Best Clinician Award at Sports Connect 3 Conference in 2021, Connect 3 Conference in 2021, AOCNR Young Investigator Award at 4th Asia Oceanian Congress of Neurorehabilitation Conference in 2021, Best IAPWC Office Bearer Award at IAP Women's Cell Conference in 2021. She's a resource person for several webinars, including webinar on mirror neurons and its implications to neurorehabilitation, organized by Sancheti College of Physiotherapy in September 2021, and webinar organized by IAP and IAP Women's Cell Delhi in July 2020. It gives me a great pleasure to welcome Dr. Uttara Mohan to this event. Welcome, ma'am. Our next panelist is Dr. Vijay Kumar. Sir, can you please switch on your video? Vijay Kumar, sir?
Yes, ma'am.
Yes, sir. Thank you so much. Dr. Vijay Kumar is an associate professor, Department of Physiotherapy, Kasturba Medical College. He's in charge of Department of Physiotherapy, KMC Hospitals, Attavara, research coordinator, Faculty Research Forum, KMC Mangalore. He's an affiliated PhD guide at Manipal Academy of Higher Education, Mangalore, Karnataka, India. He himself is a PhD in stroke rehabilitation from Manipal Academy of Higher Education, Karnataka, India in 2017. He has almost 36 national and international papers in his accolade. Welcome, sir. Welcome to the panel discussion.
Thank you.
Now, may I, our third panelist is Dr. Dorcas Gandhi. May I request her to please put on her video so that the audience can see them. Dorcas, Dr. Dorcas is presently working at Christian Medical College, Ludhiana, as an associate professor in College of Physiotherapy and research fellow in Department of Neurology since October 2013. She is awarded the Young Fellowship Award 2021 by Indian Federation of Neurorehabilitation. She developed and implemented a set of training and technical support modules on stroke rehabilitation for Southeast Asia region in collaboration with World Health Organization in 2019-20. She developed a training document on integrating stroke services in healthcare systems, a practical approach stroke care for primary healthcare workers in countries under the Southeast Asia Research Organization, WHO, in 2019. She was awarded a travel grant for young investigators by the European Stroke Organization in 2019, awarded the Young Investigator Award by World Stroke Congress in 2018. She was selected as one of the top 25 emerging leaders 2018 from across the world in stroke treatment prevention and rehabilitation by World Heart Federation in collaboration with World Stroke Organization. She had the top 10 abstracts in recovery and rehabilitation, travel award, International Stroke Conference ISC 2016 Los Angeles. She has around 21 national and international publications, and she's presented over 20 papers in various conferences. It gives me a great pleasure to invite all the three eminent speakers for our session today based on mirror neuron. So without further delay, I would like to welcome the first speaker of the day, Dr. Uttara Mohan, to give her talk on Introduction to Mirror Neurons, the Mind's Mirror, Understanding the Functions and Overview of Clinical Implication of Mirror Neurons in Various Areas. Uttara ma'am, can you please take over?
Thank you, Dr. Lakshmi Prabha.
You're most welcome.
Good afternoon to all. I'll be talking about the introduction to mirror neurons. So first we'll start with looking at what exactly are these mirror neurons. So these neurons are present in the cerebral cortex. They are activated when we imagine, observe, or perform specific motor tasks. So compared to earlier notion where people assume that only the neurons activate when we are performing the task, it was later shown by research that if the same action is imagined or observed when someone else is performing the task, the same areas of the brain activate. So the areas which activate are primary motor cortex, premotor cortex, and somatosensory cortex. So these areas are helping the human brain to recognize the goal of the action. So like we always say, the brain understands the goal or the action performed, not the specific movements or range of motion. Also, these areas are not age dependent. Any part of the age, they activate in a similar way. So how do people come to know about these mirror neurons? In 1992, Gullis et al. Discovered in animal studies, mainly in monkeys, that the same neurons were activated during execution and observation of the same task. And later with further researches, it was named as the mirror neurons. There were also parallel researches conducted by Dr. V.S. Ramachandran, which used mirror visual feedback or a mirror therapy, wherein the patient had a mirror placed along the sagittal plane, along the midline, and the patient performed the movements of the intact limb. Say, for example, the patient had a left upper limb amputation. The person would perform right upper limb movements by looking at its mirror reflection. So this created an illusion as if the left limb is moving because the mirror shows symmetrically opposite reflection. So this way it was used to treat phantom limb pain. Subsequently, it was used in many other conditions, including stroke rehabilitation. Also, there were studies by Nupur et al., which showed that these mirror neurons do activate even during a motor imagery. So how it was found that these activation occurs is that during these researches, various neuroimaging techniques like functional MRIs, electroencephalogram, magnetic encephalogram, positron emission tomography, or transcranial magnetic stimulation was used to say that which areas get activated during imagining, observing, or performing various motor tasks. So how do you activate these mirror neurons for a rehabilitation point of view? There are various approaches. Action observation is one of the ways it is done. That is, whichever task you want to train for the patient for a rehabilitation, same activities were performed by another person in front of them, or a video of the action was displayed to the patient. And by observing, patient tried to activate the mirror neurons. So accordingly, a recovery can be produced. Also, in many of the cases, it was observed that for a rehabilitation point of view, we want the patients to observe the action and also imitate it, that is, perform the task later. So, patient paying attention to various components of the task while observing helps to make them perform or imitate the action in a better way. So, there are various studies which had action observation sessions followed by performance of the same task. There were also studies on motor imagery where the patient imagines specific task being performed by imagery, and that also helped in a recovery in the patients. There are studies on mirror therapy for various conditions wherein the patient viewed the reflection of the intact limb in the mirror, and this has been used for upper limb and lower limb impairments and created recovery. Recently, there are a lot of studies on graded motor imagery. So, graded motor imagery, like the name suggests, it's implemented in a graded fashion. So, quite often, when severe pain symptoms are there, patient might even lose left-right discrimination ability. So, graded motor imagery starts with improving the left-right discrimination ability, identifying which is the left body part and the right body part. After some sessions of this, it is followed by motor imagery, imagining specific tasks which may be painful or impaired, followed by mirror therapy for the same task where the intact limb perform those activities or movements, and followed by actual movements. That is, the affected limb is trained for those movement control. So, what are the prerequisites for this treatment? So, few things need to be kept in mind when administering these interventions for the patient. One thing is patient's coordination should be intact. They should be able to understand and follow your commands. There shouldn't be any visual defects, especially in terms of, say, action observation or mirror therapy. You want the patient to observe the movement. So that's why their vision should be intact. They should have a good trunk stability in sitting position, because many of these interventions are performed in sitting. A few may be performed in prop up position, lying down positions as well. The vitals of the patient should be stable, and the visual artifacts should be minimized. For example, you have a mirror therapy being conducted. Patient is, say, a left hemiplegia. Patient is doing right upper limb movements by looking at a mirror reflection. Say the patient has a watch in the right hand. So the watch cannot be worn, will not be worn in both the hands. So it's better just remove the watch so that it looks more realistic and more effective in activating the mirror neurons. Also, background stimulus like noise or excessive bright light, all these should be minimized so that the patient can focus on the intervention. So what are the benefits of activating the mirror neuron through these approaches? Is that it improves the recovery in terms of sensory, motor function, and also in pain relief. So many patients with paresthesias have seen recovery in the symptoms. Also, motor functions, voluntary control can be improved. It's been used for various conditions in terms of pain relief. It is especially useful in patients with low voluntary control. Say, for example, you have a stroke with very low voluntary control or a cerebral palsy. You can use these interventions in early stages where there is very limited techniques, interventions that can be done for improving the motor function in the early stages. It also can be used as an adjunct along with the traditional treatment that is being followed to improve the efficacy and the recovery in the patient. And these interventions also help to recover from learned paralysis and learned pain. So what do you mean by learned paralysis or learned pain? Is quite often we might have observed this in stroke patients, that in the early stages, because of the edema and the cerebral cortex, the motor pathways don't get activated. So there is no or limited movement in the paretic upper lower limb. So whenever they try to move the limb, they see that the limb is not moving as much. So this visual feedback of lack of movement gets wired into the brain, and they start perceiving that the limb is paralyzed and it will not move. So you might have seen, even after a few weeks, months of rehab, the patient is able to perform certain tasks with the affected hand, and then they still, whenever they want to do the task, inadvertently they just get the intact hand forward and try to perform it. That's because of a learned paralysis that happens in these patients. Also, in patients with chronic pain, there are cortical changes with reference to the pain, in terms of avoidance of movement, fear of increase in pain. So these cortical changes lead to a learned pain. So sometimes when the patients have hard healing and recovery, still they have a perception of pain and they keep avoiding the movements. In such conditions, these mirror neuron rehabilitation are effective. So which conditions we have applied is in stroke patients, in phantom limb pain and spasms that amputated patients feel. It's used in chronic regional pain syndromes. It's used in cerebral palsy, especially who have a hemiplegia kind of clinical feature. It's been used in post-surgical rehabilitation, like for example, someone with severe pain after say a tendon repair or a soft tissue injury. In some cases, when the pain, it doesn't correspond to the severity of the condition, or the pain is going in a chronic phase, these interventions have helped to reduce the pain and improve the movements and the voluntary control in the patients. Also, in some cases of hemi-neglect, this intervention has been used to improve the symptoms. Thank you.
Thank you very much, Dr. Uttara, for touching upon the basic aspects of mirror neuron therapy. It was a very well given lecture. Thank you very much. Now, may I invite Dr. Vijay Kumar, sir, to please enlighten us about the mirror neuron-based rehabilitation. Dr. Vijay Kumar, over to you.
Thank you, madam. Is it fine, ma'am? Screen is visible?
Yes, yes, it's visible.
Thank you, Lakshmi, madam. And even I thank Dr. Uttara for that brief introduction about MNS system, this mirror neuron system. So basically, as a physical therapist, we'll be primarily looking into how we can improve the motor learning or motor performance. And we also look for some novelty in the approaches, like how best we can improve their quality of life. So my session is more of based on this MNS-based treatment approaches. So I'll be more of discussing about how we can clinically implement that. And with respect to the evidence and research, we look into the other panelists who will be discussing about these areas. So before we go into that, my overview of this session will be about how the cognition is connected with the motor system and the currently available MNS-based approaches like action observation, execution therapy, motor imagery, and mirror therapy. And we'll be discussing about few merits and summary of this session. So to know about the difference between movement and action. So movement is just a kind of a displacement of your body part in a physical space, like what we do in flexion or abduction or rotation. But if you look into the action, it's a series of movements that is to achieve a particular goal in their physical and social environment. So these two pictures talks about the goal of drinking a cup of water, but you can see that action is different. The movements are different. So the action is planned with respect to specific goal. So what is the information from that is, before we produce our own actions, we have mental process. So that involves the planning, preparation, and production of our own action. So even if you want to play a violin, so there are a lot of motor areas involved in that to prepare that our own actions. So as Uttara madam has said, like we have a lot of areas involved in motor cortex, premotor cortex, supplementary motor cortex, temporal gyrus, and even the frontal areas. But it's not like that. We need a mental process to produce our own actions. We have also able to understand the actions of others' behavior. So just by looking at their motor behavior, we can able to understand what is their goal of action. So the mental process also involved in recognizing, predicting, mimicking, understanding the behavior of other people. So that's the thing. Our brain has the ability mentally to represent the actions made by other people. This is based on the concept of motor representation, shared motor representation. So all this information lead to a development of field called cognitive neuroscience. So what this basically talks about is this area of science. It integrates the cognitive psychology and the neuroscience. So based on these few features, the researchers started to work on in these areas. At the same time, in the past few decades, we have the major advancement happening in the radio imaging techniques so that they can able to understand the neural firing happening in the system. So these imaging techniques and these advancement of cognitive neuroscience, they can able to identify certain neural subsets so that the mental process involved in our own action or understanding of the other behavior people can be understood. So that leads to what we call it as mirror neuron system in our human body. So mirror neuron system, basically, we can able to observe, imitate, or imagine a movement or an action that facilitate making a similar motor response. So this we call it as mental simulation of action or motor resonance. So what is the query in our rehabilitation? There are few queries. As I said, physiotherapists, we are more interested to improve the motor learning in the patients. So do we need to actually execute a movement to facilitate this learning process? Or just by imagining or observing the movement of any movement or motor skill without executing can improve the motor performance? Can we have any novelty? Still, we are working on with passive movements, passive stretching. Yes, we need to have some novelty strategies to improve the motor skills. So all these queries we are answered with a specific cognitive tools for relearning motor skills. Thus, the presentation, the identification of mirror neuron system lead to integrate these cognitive tools of relearning motor skills. So at present, currently in neurorehabilitation, we use three basic treatment approaches based on mirror neuron system: action observation therapy, motor imagery, and mirror therapy. So we'll be briefly discussing how to implement clinically about these approaches. With respect to action observation executive training, Uttara madam has already discussed that we have to show some performance of the activity or a task, or we can use some videos. But the main point here it is the observation with intention to imitate. It is not just observing. After observation, the patient has to imitate that particular task or activity. So most of the studies, before they execute the action, there are a few minutes of action observation training has been given. 2 minutes for action observation, followed by 3 minutes of action execution. But there are few factors which can influence this cortical modulation. That is, what was the subject experience about the task, what she is visualizing from the videos, on which perspective she is visualizing the video, and what type of actions are involved in that video. So what it means? You mean here we see a subject watching a video of walking, the subject is walking, and it may represent the activation of the motor area similar to our inner brain. This is a very simple task where the patient can be asked to view this video and she can able to recruit the motor areas. But if you create a videos or action like this, which subject doesn't have any experience of that particular activity, which may not able to produce that cortical modulation. So the task or the activity which you are going to produce in the video or in the demonstration, the subject should be familiar with that or should have some prior experience about that particular task or activity. Okay, the next parameter is perspective. So which perspective we are going to show the videos, whether it's a first person perspective or third person perspective. So most of the time it has been shown that if you just watch some other person is doing the activity, or in first person perspective, the videos which is shown in the laptop, it shows like you are only doing the particular task or activity. The first person perspective always shown to be a better improvement or significant changes compared to third person perspective. So they also recommend, like in action updation training, it is better we make videos in first person perspective rather than third person perspective. Transitive versus intransitive motor actions. So intransitive motor actions, you can see that you are facilitating the grip strength or the precision grip, but there is no appropriate objects in the hand. So this kind of task may not be able to produce a significant cortical modulation. So even when you're going to make videos or tasks, there should be a goal oriented with appropriate environmental modification. So if you're going to use for grip strength improving, there should be an object in the hand holding the object. There should be something in the hand to facilitate the grip strength. Instead of just doing the simple movements, it is better to facilitate the transitive actions in the videos or in the demonstration. So you can see that the subject is performing just doing some opposition movement. In the other picture, the subject is doing a task which is somewhat more significantly improve the cortical modulation. Thus, in action updation training, these three parameters are very important to facilitate the cortical modulation in the damaged neural system. The other concept is about motor imagery. So what it means? It means a mental process where the individual rehearses or simulates a given motor act without actual movement. So here, the subject is imagining that he is going for a brisk walk in an environment. It doesn't mean like you're going to be going for only a task. Even it has been shown that even you can imagery the movement or an aerial functions also. Basically, the concept of motor imagery from sports psychology and behavioral psychology in the 19th century. But as I said earlier, the recent development in the cognitive neuroscience and physical rehabilitation had improved this application in neurorehabilitation also. So what is this motor imagery? It means the active state of reproducing motor representation of a specific motor action within the working memory without any motor output. So before you do the activity, there is some mental rehearsal happening there, how we are going to do that motor activity. The key point here in the statement is motor representation. What it means, actively you are going to produce that motor representation. So motor representation is the basic component of any complex functional goal-directed movement. It has been stored in the motor memory as perceptual trace. So I like to give an example. Suppose if you are looking for a motor representation of drinking a cup of tea, there are 10 number of basic action concepts involved in that. That means first reaching for the cup, grasping the cup, lifting the cup, bending the arm with the cup, putting the cup into lips, tilting the cup, closing mouth and swallowing, straightening the arm, putting cup down and letting go of the cup. So this we can divide into three phases: preparatory phase, execution phase, and completion phase. So like this. So the first four pictures talks about the preparation, the execution, the next three pictures, and the last three pictures talks about execution phase. So if you are planning for an activity for motor imagery, it's better to have this kind of pictures so that we can be able to know the sequence of the movements that should be followed in the particular task. So this we call it as basic action concepts or motor representation of the particular task. So the basic action concept or motor representation can be described verbally or through visual images. Either you can show the sequences visually to the patient, or you can verbally discuss about the sequences also. So this can able to detect the motor planning faults, and it also improves the feedback efficiency. So type of motor imagery. So in the literature, we have basically visual and kinesthetic imageries. So visual imagery is just you're going to visualizing that you're going to do the particular task. In kinesthetic imagery, you're going to feel the action of the muscle, even the joints during the particular act. So it's more of a sensory motor information. In visual imagery, it's more of a visual information. So is there any difference between the terms motor imagery and mental practice? Motor imagery is just a cognitive operation, but mental practice is a training method. So we have a lot of steps involved in that, how to integrate this motor imagery in practice. So what are the steps? The intervention framework for motor imagery or mental practice. First, you have to assess the mental capacity. You have to explain the patient the nature of the mental practice, like how we are going to do, how we are going to follow the task, how we are going to imagine all these things. Then you are going to embed and monitor, and you can develop the self-generated treatment also. So how to assess this mental capacity? Basically, we need good cognitive function. As Uttara Madam mentioned, that we need to have basic cognitive functions, attention, working memory, and motivation. How we can make the motivation? Choose a task which is subject is more interested to do that. And they can able to follow the 3-stage command. Basically, we go for mini mental status examination screening tool. And we have specific motor imagery screening tools also available for neurorehabilitation population. So once you're done with that, how to familiarize the motor imagery training. So specifically to the functional task, which is patient is more interested, demonstrate, and you identify the problem. Suppose in the same task, cup of tea, whether the patient has problem in reaching the elbow or grasping the cup, whatever the problem, you have to identify it and ask the patient how to improve that, strategies to overcome that. And remember that feeling and movement consequences which are associated with the success and errors. And also verbally describe what they did for the improvement. So who can be benefited? Subject should have all the components of mental capacity, including the imagery ability, and there should be some sparing of sensory motor network system. So whom we can be having much not beneficial? Those patients who have parietal lobe lesions, subcortical lesions, problem in the cognitive functions, perceptual functions, and even the communication problems with severe motor deficits, there are limited application of motor imagery in them. So when you're going to integrate mental practice, so most of the studies have shown that you start with mental practice, then go for physical practice. Because once you do physical practice, they may get tired. The fatigability can influence the mental practice program. Select a place where there is undisturbable environment. Either you can ask the subject to sit supine in the supported chair. Most of the studies, they're given some audio feedback also, like about the task, the correction, and movement sequences. So if you are going to have an audio feedback method, it includes 3 parts: relaxation period, description of the motor task, and refocusing to the room and situation. So during imagery, the subject initially can perceive as visual imagery, then progress to kinesthetic imagery. During imagery, the patient should not make movements. And whenever they do the imagery training program, they can verbally signal the beginning and end of the each task. You may also require to measure physiological changes to see the changes happening in the motor imagery training program. Sometimes even they are using some metronome beats to coordinate with the movement task. So what's the difference between this action observation and motor imagery? In action observation, there is additional visual exposure to the task, so less cognitive demand. So subject with limited cognitive potential, we start with action observation therapy. Subject has good imagery ability, but mental fatigue. Then you can go for this motor imagery training program. That's again now the important parameter which can influence the motor imagery training program. So subject should have good imagery ability and should have good mental ability to focus the training program. So there is new concept developed in the neurorehabilitation is imagined imitation. That what they do is they do both this therapy along with the treatment. Like subject will be initially go for motor imagery and also action observation, then followed by the regular physiotherapy program. So what we call it as AO plus MI approach. This we call it as imagined imitation approach in neurorehabilitation. So coming to the third method, mirror therapy. So it is basically we can use in acute phase of rehabilitation. It provides an add-on information to the brain so that if your system is not moving properly, your limbs are not moving properly, the sensory motor map may get diminished. So to activate this, we can use this mirror therapy. So what is mirror therapy? We know that it's an illusion that both the limbs are functioning properly. So there are certain features required for the patient to go for mirror therapy: motor abilities, cognitive abilities, and vision, and trunk control with good vitals, and also the non-affected limb should be normal and pain-free range of motion. So before mirror therapy, inform the patient about the aims. So that means the patient should watch the reflection of the image, not the movement of the limb, which is going to produce by the unaffected limb. And distraction, the jewelries, other things should be reflected or it should be removed from the treatment session. Positioning, basically we are looking to position the patient in the midline of the patient. Patient should be comfortably placed and it should be placed in the sagittal plane or midplane so that they can see the reflection of the limbs. So how we progress in the mirror therapy? Initially, we start with simple movements of the non-affected hand or arm, just the reflection, abduction, opposition, and all these things. Then we follow by close chain activities, holding that paper or a cloth, just rubbing the table, followed by a functional task. Later, we can also progress by guiding the affected arm by the therapist. So these are some of the methods they can be applied in the mirror therapy. So what basic mechanism the mirror therapy works on is, it maintains it creates that, reduces the intrahemispheric balance. That means the excitation of the damaged cortex is increased, excitation of the contralateral cortex is going to get reduced. So this intrahemispheric balance is going to get happen during mirror therapy. So whatever the cognitive tools, what we use, basically it targets the ipsilateral motor cortex. It strengthens the motor representation memory, activate motor planning, improves the sensory motor inputs, and also the hemispheric balance. So merits of these approaches, it's very simple, less expensive, supportive evidences are there, early intervention, less adverse effects, and feasibility. So with respect to research,
sorry to interrupt you, sir. We need
last
to
two
just
slides.
Thank you so much.
Two slides. There are research. There are many approaches combined with that, many other treatment methods, and also the optimal dosage. Still, there is a debate happening with the optimal dosage. So, summary: these priming tools can be used to increase the excitability of motor system, and it can accelerate the reorganization of cortical motor loop, and it is used as a complement, not a substitute to the physical practice. So, what matters most is how you see yourself in mind. Thank you, madam.
Thank you so much, Vijay Kumar sir, for giving us a wide way of thinking of motor neuron therapy as a part of motor imagery, and what are the basics of motor imagery. And we are very happy to have you here. And the idea, the concepts, and the different techniques that have been explained by you very well as to how to progress in mirror therapy solves a lot of queries, I think, of the audience. So thank you so much, sir. Now